Hello, and welcome to today's ICU Liberation webinar on Interprofessional Team Coaching in the ICU, Session 1. My name is Diane Byram, and I will be moderating today's webinar. I am joined by Vishaka Kumar, Manager of Quality with SCCM, and we will focus our shared learning today on interprofessional team coaching. A recording of today's presentation will be available at www.iculiberation.org within 3 business days. Please take advantage of this resource to further educate your colleagues. I have a few housekeeping items before we get started. There will be a question and answer session at the end of our call. If you have a contribution or a question, please type it into the question box along with your hospital name. Questions will be addressed at the end of the session. Don't be shy. We are all here to learn together and very much want to talk with you during this session. You will also have the opportunity to participate in an interactive poll. When you see the poll, simply click the bubble next to your choices. Interprofessional team coaching in the ICU, our session objectives are to describe the purpose, key abilities, and success factors for their interprofessional teams, explore IPT practices that facilitate successful bundle implementation, and identify a test of change for your IPT to conduct and report back next session. This activity is eligible for CME credit, and information on how to obtain that credit will be available at the end of this webinar. I would like to present or introduce you to our presenters for today's webcast. Mary Ann Barnes-Daly is with Sutter Health, a clinical improvement specialist, ICU Steering Committee member, as well as West Coast Regional Faculty. Dr. Barnes-Daly co-authored the book chapter Using an Interprofessional Team Approach to Implement Evidence-Based Practice in SCCM's publication on ICU Liberation, released in 2015. Dorothy Lindgren is also works for Sutter Health as a team development coach. Dorothy created the first interpersonal team curriculum, which is now being used system-wide to support the implementation of the ICU Liberation to implement the ABCDEF Bundle. The disclosures for today's faculty are noted, and now I will turn the presentation over to Mary Ann and Dorothy.
Good morning, or I think afternoon. I'm Dorothy Lindgren, and want to work with you on talking about interprofessional teams. I was listening to you, Diane, and I know that that is a mouthful sometimes to be able to say, let alone to know what an interprofessional team is. So we're going to spend our time walking through that. Our purpose here is to really define what interprofessional team is and what it looks like. And so first, let's be clear about the purpose of an interprofessional team. Mary Ann and I have worked very closely with many interprofessional teams. We're doing that right now to implement ICU Liberation. And those teams really work mostly on collaboration. How do we collaborate with each other in order to both implement the ABCDEF bundle, but also to make sure that the use of it is sustained. So we're going to talk about today more closely what those teams look like and what they do.
Good morning. This is Mary Ann. I would like to share with you what's on the screen, where you can see depicted some different models of how teams operate or function in the ICU. On the top left, you'll see what we call the traditional model, where there is expert decision-making, usually by one individual that is typically the physician. The physician will, for instance, go in and see a patient or patients, review the patient's values on the chart, write orders that are meant to direct the folks underneath, nursing, respiratory care, rehab, or pharmacy, and then those orders ultimately reach the patient. This is considered traditional and probably less functional and not much about collaboration between the team. The next model below that is something that many of you have either recently experienced or are currently experiencing in your ICU right now, and that's multidisciplinary. What's improved about the multidisciplinary model as opposed to the traditional one is that there is interaction between different disciplines to the decision maker. It's called a consultative decision-making model, where individuals from nursing, pharmacy, rehab, and therapy, for instance, provide information and consulting into a central decision maker, typically the physician, who then renders the decision. You'll notice then that to the right in the larger model is a depiction of what an interprofessional care team does, how they look, and more importantly, how they function. The first thing you'll notice is that at the center of the wheel is the care, or the patient's care plan. What this also shows is that every individual or discipline or role in the circle has an equal size slice of the pie. In here you'll see not only the physician and the nurse, the respiratory care practitioner and the physical therapist, but also the patient themselves as well as their family, and other folks who have important contributions to make to the patient's plan of care, such as nutrition therapy, social services, and so on. What you'll say is, what I see here is a lack of hierarchy. In the other two models on the left, they definitely depict a hierarchical structure, and typically the physician is in charge. What you see in the interprofessional care team model is that hierarchy is removed. Every individual is considered an expert in their own domain, even the patient and the family. They are the most expert about themselves and the patient. You'll say then, how do we remove the hierarchy in a structure like this? We understand that not every person who has a slice of the pie has the same training, experience, expertise, or education. But we do recognize that each of these folks are experts in their own domain, and they do have a significant and important contribution to make to the plan of care. They should be recognized as experts, and they should be given an opportunity, and we'll talk more about how to do that in rounds, to provide results of their assessment, their experience, and most importantly, their recommendation about how patient care should progress.
Thanks, Marianne. So we're looking at moving then from expert decision-making to consultative, and then ultimately to collaborative decision-making. We're interested in how this looks for you currently. What pieces of the interprofessional team you have implemented. So the polling question is, how are you currently functioning as an interprofessional team? So what we'd like you to do is use your check marks to check 1 item, 2 items, 3 items from the list below that define your function as an interprofessional team. So do you attend and participate at meetings, strive to include patients and family in care decisions, collaborate to decide how the ABCDEF bundle will be implemented? Do you learn together? Do you learn from the research and then change your approach based on what you learned? And do you identify process changes needed and work to implement them?
And as asked in the question, this is not how you function, but how your team functions. So the answer is all my team members, and then choose your answer. We'll give you a few seconds, and then we will show the answers.
Okay.
So we can see here that the majority of you do most of these things, or your teams do. So attend and participate at meetings is high. Striving to include patients and family is almost 3/4, which is really, really great to see. Collaborating together as a team to decide how the ABCDEF bundle will be implemented, a little bit over half. Learn together. This is really important. It's important for teams to understand the why and that this is not just another or additional thing to do in their day. And really important, I'm glad to see that you can identify process changes needed and you work together to implement them.
Okay, great. This assessment was built on the work by Dr. Carol Orchard. She developed an assessment of interprofessional team collaboration scale, and it is a similar interprofessional team definition that we're using here. We modified it with permission from her, and we're using that definition with the ICU Liberation Collaborative. What we saw in the initial data that we collected is somewhat similar to what you reported there, but really some improvement needed in the following areas. One is the area of understanding what an interprofessional team does and that it really is a unique approach to implementation of the bundle. We saw it specifically around coordination. Coordination, the need to really get some new processes in place, some new ways of acting, some new scripts, some new policies, some new procedures, some new checklists. We saw it in the areas also of cooperation, the need to really change how I individually work with others. So we can focus on that here today to really learn how to enhance or share power. What are some tools to do that? How do I resolve conflicts with others? We'll focus on that today and more in session 2 as well. And then on partnership, the need to include each other and our patients, as many of you are doing when we make ICU care decisions. So your results really mirror some of what we saw, that some of this is happening, but then there's also some improvement that's needed in those specific areas. So what is an interprofessional team? I think we've defined specifically around the collaboration piece. I'd like to outline for you what an interprofessional team does and what collaboration could look like. So first, it looks like partnership, and this is a phrase many of you are familiar with, or maybe you call it teamwork, but this is the part where you create open relationships, respectful relationships, you work together to achieve outcomes together, meaning you, individually, meaning your team, and meaning the patient.
And this doesn't just mean creating an open relationship and respecting other members of the team. It actually goes one step forward further, where you create a space or an opening for people to feel comfortable and confident to share information that ultimately is going to help create the patient's care plan. This is particularly important when we're talking about patient and family. Again, I was happy to see that so many of you include the patient and family in your creation of care plan, or maybe perhaps even in rounds. It's not just asking or inviting, it's creating an inviting space for them to take part in your process and also to feel comfortable, and not just comfortable, but be asked to contribute what they have to share with the team.
Excellent. So it's not just teamwork, it's also the space for teamwork. And then coordination really looks at that word process. What processes do we need to put together? What processes do we need to integrate or create to get at our goals? And then cooperation is really all about you individually. It's how do you listen? How do you value what you're actually hearing from other team members? And what do you do with that information that you get? Remember, that circle's pretty large. You're getting lots of information from respiratory and physical therapy and pharmacy. How do you really listen to those viewpoints and then change or contribute based on what you're hearing and what they're contributing?
And in the coordination piece, I think many teams would assess themselves as working well together. One of the things, though, is to look at not just are we doing okay, but how do we examine our processes and look for areas of improvement so we are actually focusing on continuous quality improvement and moving forward, not just integrating new evidence and new ways, new or more efficient or better ways of doing things, but also to think about how can we move from good to better to best. And it's really important to coordinate with the entire team to look at things like workflow. And also, how do we coordinate together based on the people who are on our team, their personalities, the human factors involved, and also how do we work best and how do we optimize each person's contribution so that we can be a coordinated team. And then as Dorothy pointed out in cooperation, again, not just valuing and showing an outward sign of respect, but taking it one step forward to actually elicit response and input from your team members to let them know and also model for others that you value each person and each person's contribution, and you model to them to do the same.
Okay. We also realize that as we go over these key abilities, it's easier said than done, and we are going to give you some specific strategies that have worked for many of the teams that we work with. Everyone tries something a little different, and we're going to get to that in just a minute. We also, though, want to point out that middle circle of this interprofessional team model that talks about roles. Understanding that to make an interprofessional team successful, 3 role areas are critical. First one being role clarity. So in order to be a contributing member on an interprofessional team, you really need to understand everyone's role and not what they know, not their knowledge. You don't need to have their knowledge, but you do need to understand what they know and what they bring to the team. And then there's role valuing, so really respecting them based on what they bring, their knowledge, their contribution. Respect often looking like listening to them and looking to them for that knowledge and that contribution. And then lastly is role sharing. So a willingness to give up or share some of your power regardless of the level of education or professional preparation that you walk in with, really understanding that need to share that power with others who have different but critical education and preparation.
To further what Dorothy said, when I was first learning this model many years ago, I often had some confusion between role clarity and role sharing. So in addition to knowing and understanding others' roles and their knowledge, it's really important to understand what your personal role is as a team member and being sure that you're contributing in a way that optimizes your expertise and experience and your interface with the patient so that you are a patient advocate in every possible way. So it's important that you own or take your part or stand into your role when you are working with others. At the same time, with role sharing, it's important to know that others may have similar experience or expertise as you in certain areas. So for instance, for the physician and the respiratory care practitioner, both are experts in their own domain about maybe pulmonary function, respiration, the use of the respirator or ventilator. So it's important then to understand how each has an important and unique role for the patient, but also understanding, for instance, in the case when we're doing spontaneous breathing trials and we're talking about decisions around extubation, that being able to share the power with each other to work collaboratively, to understand each other's role, and to share decision-making in a collaborative way to best serve the patient, in this case, for earlier extubation.
Yeah, and when Mary Ann was talking about this need to create a space in which to practice as a team and work as a team in partnership, we have really seen rounding being a key place and a key space to do that. What we're going to do now is show you a rounding video example. What I will say, and I think Mary Ann will reiterate here in a minute, is that your rounds will look different. They look different throughout Sutter Health where we're working. All the 20-some hospitals that we're working with, the rounds look very different there in each place as well. But the idea of partnership and collaboration and some of the tools that are used can really, we think, benefit all of you. So we want to show you an example of that.
The purpose of this video is not to show you how to conduct rounds. It is to show you what Dorothy mentioned, is the collaboration, cooperation, and decision-making that is done amongst the team members. And also, it serves as a template so you understand what areas need to be addressed for the bundle, the language that is used, the way that the professions or disciplines cooperate and collaborate with each other, and with the patient and family. I'll state two things about this video. When it was made a few years ago, the bundle was ABCDE, and so it does not reflect exactly the content of the new and revised ABCDEF bundle, but you can see that the tenets are basically the same. And also, for a reason beyond our control, there's somewhat breakup or pixelation of the video and a little bit of a voice delay, but we reviewed it and feel like it's still valuable to show. Mrs. Bingham, my name is Mary Ann. I'm your nurse we met earlier today. And you are Mrs. Bingham's sister? Very nice to meet you.
Good morning, Ms. Bingham. I'm Dr. Oribello. I'm your physician, and we met the other day when you got intubated, but I'm sure you don't remember any of that.
Hi, Ms. Bingham. My name is Alex. I'm the critical care pharmacist.
Hi, Mrs. Bingham. I'm Kelly from Respiratory Therapy.
Hi, Mrs. Bingham. My name is Sionita. I'm your physical therapist today. Hi there.
The other day when we came in to evaluate her, she was quite hypoxic, and on x-ray she looked like she had a big consolidation on her right upper lung, and it must be part of the contusion from the trauma, and she might have aspirated at that point as well.
When she came over to us on transfer the other day, she was on, after intubation, she was on a fentanyl drip and a Versed drip, and her RAS was -4, so we couldn't perform her CAM. Yesterday, she was still a RAS -3, and she was found to be CAM positive. We changed her sedation at that time from the benzodiazepine to propofol. During the night, though, she was still a RAS -3 and CAM positive. This morning, she was a RAS -2 to -3. As you can see, she's still intubated. She met the inclusion criteria for the ABCDE bundle. She's on continuous sedation and propofol and continuous analgesia on fentanyl still. Her pain scale is 0 through 8 on the CPOT. Her target RAS is -2 to 0. She was a -3 this morning before I turned off her sedation. She did pass the spontaneous awakening trial safety screen, and I turned her sedation off at 8 a.m. And I did not stop her narcotic at that time because of her rib pain. She did pass her SAT. Her RAS went from -3 to a -1 during the trial, and I was able to leave the sedation off for the spontaneous breathing trial.
So this morning, Mrs. Bingham was able to pass the safety screen. We went ahead and did the spontaneous breathing trial in CPAP of 5, pressure support of 0. She did very well. Her RSBI was 50, and her NIP was actually -30. I also gave her some instructions on how to splint those ribs to reduce the pain with her spontaneous breathing, and I believe she's ready to be extubated. That's what my recommendation is.
Excellent. I agree that she is ready today. I saw her earlier, and it looks like her oxygenation is doing well. She's not requiring as much support, and we'll plan on extubating her after we're done with these rounds.
Okay, I'll be available.
So I think we were able to coordinate our SAT and SBT pretty well. I had the sedation turned off by 8 o'clock, and you came and did the SBT.
Yeah, it was wonderful. I appreciate you turning it off early. She was ready to go and for me to do the trial at 8:30. Thank you.
Awesome.
Well, considering she's going to be extubated, the new PAD guidelines recommends an analgesia first approach with PRN analgesics, and if pain's not controlled, we should go to a drip. Her CPOT score is 0 out of 8, so she's well controlled with her pain. She doesn't need the propofol drip, so I recommend DCing the propofol drip, DCing the fentanyl drip, and just using PRN fentanyl as needed for pain.
Excellent. I'll write an order for that as soon as we're out of here.
Great. So in terms of delirium, patient, as I mentioned, has been CAM positive over the last 2 to 3 days. When I came in this morning and did my initial assessment, she still was CAM positive. But I reassessed right before rounds, and I noticed that since her sister's been here talking with her and reorienting her a little bit, patients now chem negative.
I assessed her yesterday. She wasn't ready. She was at level 1. And when I assessed her today, she seems to be ready for at level 2 mobility. She has passed her safety screen, and I would like to get her going with her mobility once she's extubated today.
Okay, we're looking at extubating her in the next 60 to 90 minutes. So I'll page you and let you know when that's going to happen, and then we can come up and get her moving.
I'll be right back.
Okay, great.
So will her ribs hurt when she does the physical therapy? As the pharmacist suggested, she's going to be getting intermittent pain medicine. So before therapy, we'll make sure she's medicated so she will be comfortable during the treatment.
Okay, so team, is there anything else that you'd like to bring to the table? Any other comments or questions? Do you have any questions for us? Okay. Mrs. Bingham, it looks like it's going to be a busy day for you. We're going to pull that tube out today, and then we're going to get you started on your early mobilization.
So in addition to that slide, I would like to thank my Sutter Health colleagues who played great roles in creating that video, including the patient and family member. Those are also our colleagues. So we're happy to be able to share that. We've gotten some feedback about that video, that there are some things that maybe we might have revised. So for instance, if I was laying in bed and the patient and heard I was going to be waiting another 60 to 90 minutes to be extubated, I may take some displeasure with that. The other consideration, and we talk a lot about this with our rehab colleagues, is there's often a feeling of the need to wait until the patient is extubated before mobility occurs. And what our national expert Heidi Engel from University of California, San Francisco tells us is that it's often to the patient's advantage to ambulate before they're extubated. It allows them to be more awake. It improves blood flow to the lungs. It improves their ability to overbreathe a ventilator and re-engage their respiratory muscles. It helps them to clear secretions and just makes them more engaged in care so that there may be a higher likelihood for successful extubation. So while in this video it says that we're going to wait until after the patient's extubated to mobilize, that's not necessarily required or even recommended. So I just wanted to bring those points forward. If any of you have any other comments about that video, please feel free to share those in the form of questions or comments at the end of this presentation.
I also want to point out the wonderful collaboration that you saw and the tools that were used. So you'll notice that, you probably noticed that everyone had something in their hand, which is a script. We'll talk about that in a minute, just as a tool for everyone to be on the same page with rounds. The fact that they were at the bedside. Many of our teams that we're working with currently are working very diligently to get rounds to happen at the bedside, which often means really getting only the people needed there. And you probably noticed just actual timing coordination. You know, we met at this time, we did the trials at this time, and so it really does use rounds for all of us as a way to coordinate and as a way to collaborate. We want to give you some strategies for implementing interprofessional teams in collaboration. Did you have something to add, Marianne?
Yeah, I just wanted to tag on to what Dorothy said. Is you heard us talking about how we did coordinate so that we were demonstrating that we, for instance, coordinated on the SAT and the SBT. But what you also saw in that video was planning. So coordinating with team members around when things should happen, what the expectation was, and to make sure that these types of activities were accepted by all and also could fit into folks' schedules. And people are open to working together when they're asked about times, availabilities, and resources.
So we're going to give you now some strategies to implement interprofessional team collaboration. We advise you to really look at these and pick one that you think, yeah, I'd like to work towards that, either as a team or as me individually, because we are going to have an assignment, a test of change experiment for you to be done between session 1 and session 2. So the first strategy that we'd like to recommend is that you utilize a rounding script. So a rounding script, again, gives everyone the opportunity to be on the same page around who's speaking and how are we covering each of the bundle elements.
There's two ways that we've seen rounding scripts work well. One is to have an overall rounding script that directs or is literally a script for what people say, discuss, and contribute during rounds. So it's kind of like a screenplay for how rounds goes for each patient. Another way to utilize a rounding script is to create specific rounding scripts for each discipline. One thing that we know about folks speaking up in rounds is that no one wants to feel like they don't have the right information or don't sound smart. So what teams have done that has worked well is they've created scripts or pieces. So for instance, in the rounding video that you saw what the nurse contributed, what the pharmacist contributed, and so on. So providing unique scripts which allow the individual professionals to know what the expectation is for them to have assessed, provide during rounds, to discuss, and most importantly, we'll talk about to recommend. So again, to summarize, a large script or screenplay for how rounds are going to go overall. Into that, you would incorporate the content of the ABCDEF bundle wherever it makes sense for your hospital or your unit, so that things flow and answers are given to important questions in addition to the ABCDEF bundle. And then creating a unique or carve-out script for individual professions like nursing, respiratory care, physical therapy, even physician, to know what it is around the bundle that they're expected to have assessed and know prior to rounds, what they're expected to share during rounds, and what types of recommendations we would like them to make at the conclusion of their portion of the presentation.
The next bullet here, the next strategy, can be taken on its own or also incorporated with the rounding script piece. So this idea that each person present in rounds uses, when they speak, uses the language of I recommend. So I recommend we extubate. I recommend we do get to level 3 mobilization, that type of language. So many of our teams have begun to add the I recommend at the bottom of each of their contributions on the rounding script. So right there on the script, it says I recommend blank, so that everyone remembers that their contributions come in terms of a recommendation, and that's how you begin to build collaboration and really some leveling around roles.
One of the things that we found in our teams, both in our pilot project and our first 7 hospitals, and we're also seeing this now as we spread to other 18 hospitals, is this unintended consequence, which is really an unintended positive outcome, is that folks are more engaged in rounds. Not just because it's a test and they're going to be asked to contribute, but because there's a space for them to contribute and be recognized as an expert, and also to make recommendations around what they think should happen for the patient. I've heard so many times different disciplines say, I always think I know what should happen, but it doesn't happen. And one of the reasons is because they don't say it or ask for it or recommend it. And so knowing that their recommendations are going to be heeded, discussed, and decisions are going to be made in a collaborative fashion where their input is key, really helps them to improve their contribution in rounds, their willingness to be there. And also what I've found is, just anecdotally, folks telling me that their job satisfaction has increased tremendously. This is particularly true for professions that don't normally have such large presence in rounds, such as respiratory care, rehab, and pharmacy even, although they often have a large role. So there are many important reasons as far as patient care why this is important and the right thing to do. But remember that we also want happy, contributory, and staff that are interested, engaged, and passionate about this work. And that's what we've seen happen as a result of allowing folks to contribute and recommend.
And then another strategy to begin to get to more interprofessional team collaboration is to involve the patient and family more. If you remember from your polling results, that's something that many of you are doing, and some of you are striving to get to even more involvement around patient and family. So when we say ask patient and family for input, that looks different in every place. So what we see sometimes is that there is a set time for rounds, and but specifically the family members know when that will be, and they make an effort to be there during that time. Marianne will talk to you about some of the ways in which people talk to the family members to make sure they understand how to get their input really heard. And I think that the other piece on this is moving to the bedside. So trying to get the patient and family involved by being there with the patient. It is a stretch. Many of our teams are outside of the room, and the family member comes out, and that works as well as they make that transition. But really think about what would it take to have even more collaboration with the patient and family.
Thank you, Dorothy. I think this is one of the areas that creates the most trepidation amongst our teams. Often folks don't want to discuss how they're caring for the patient, how the patient is doing, in front of the patient themselves or the family. I think we all know that in general in healthcare, we're moving toward more healthcare transparency, and we are allowing family and patient to know, learn, and understand all facets of their care and be able to contribute and give us direction, because it is ultimately their decision around their care. The other area that often creates some consternation is teams saying, you know, our rounds are so long already. Adding these additional bundle elements, but particularly asking the family to take part in rounds, is going to really unnecessarily delay our rounding, and it's just going to take too long. And I have to say that there are two strategies to prevent that from happening. The first is, as Dorothy mentioned earlier, kind of prepping the patient and family for rounds and saying, for instance, we start rounds at 9 o'clock. You're in the 4th bed. We'll probably be here around 9:20. We'd like to invite you to attend if you'd like. If you just want to listen, that's fine. Please provide any important information that you think the care team needs to know. We also have time for 1 or 2 brief questions. If you have questions that are more in-depth, we're happy to come back and speak with you when rounds are over, after we have the opportunity to visit with all the patients in the unit. What I've seen, my own observations and feedback and anecdotal feedback that I received from teams, is that I have never heard of a case where a family member has monopolized rounds. Most of the time, they just want to hear what's going on. So of course, we shouldn't say things like aspirated to patients and their families. We should use lay terms when it makes sense. If they have questions about specific lab tests, it's probably okay to take the time to explain to them then, because one of the things that my physician colleagues have told me is, when I participate in rounds and we talk about these things, particularly with the family members, but also with the staff, it turns out that I get less phone calls later, I get less requests to come and have individual talks with family members, because they've heard most of what they needed to know. They've asked a few small, brief questions about things that were unclear to them, and they're really relatively satisfied by observing the team devoting so much time and attention and direction toward their loved one that they feel comfortable just visiting with their loved one in the room for the remainder of the day. So that's also important. The other way that to prevent patients and families from kind of overtaking your rounds and delaying them is to do patient and family teaching prior to inviting them to rounds. So some teams have had success with passing out brochures that describe what ICU delirium is. Also providing information and education around the bundle itself, and talking about why we are doing things like not sedating the patient so they don't remember this horrible experience of the ICU, why it does them more harm than good, why we wake them up and we want them to engage with us and with their family members, why we really move toward getting them out of bed, at least sitting, even when they have a lot of tubes and wires. Explaining the why to patients and families, just like we need to understand the why before we change, is very important, And then the next step then is to engage the family and even the patients themselves in meeting the goals of the ABCDEF bundle.
So another strategy after looking at maybe possibly including the patient and family is to set a goal to reduce the length of time between when the team decides to do something, such as extubation, mobilization, and when that action is taken.
One example of this is extubation. And again, as I commented on the video, in my health system, the majority of our hospitals, out of about 25 acute care hospitals, are in the community hospital setting. So typically there is only one physician and maybe 1 to 2 respiratory care practitioners. But in your instance and in some other hospitals, there may be a nurse that has 2 patients and a respiratory care practitioner maybe that has 2 to 4 patients. So as they peel off of rounds, they may say, doctor, if you're okay, we're available to do the extubation now. And while you're on the unit, I think it's a great time for us to observe the patient and to report to you if we have any problems. So again, that's a way to reduce the time between something, for instance, like the decision to extubate and the actual extubation. Particularly if we've had a patient that we've woken up for an SAT, they're awake, we're talking about extubating them in front of them. I think you all have experienced patients who, when they're awake and we tell them the tube's coming out, they want it out yesterday. So this is also a way to improve the care for our patients by not delaying them. One of the most important things around setting goals is not just to set goals around our schedules and our availability. We really need to set goals and importantly consider what's best for our patients. Maybe instead of saying, okay, respiratory care practitioner, we can extubate this patient when I get back from break. Maybe we say, let's go ahead and do it now. If you can stay with the patient for 10 minutes, I can go ahead and take a short break and then we can go back and trade off. So again, goal setting is super important where we have that patient's care consideration in the center of the circle and that we strive to create goals and to meet them based on what's best for our patients, but always, of course, recognizing our time, availability, and resource.
And having a goal, also having a time frame for team members to coordinate. So maybe a strategy of yours could be looking at, can we get a time when our physical therapists are in the unit so that we know that between 7 and 9 they're both assessing and available to coordinate mobilization? Can we get a time when spontaneous awakening trials happen so that we know when we can do our spontaneous breathing trials and move forward?
Another example of that sort of thing that Dorothy alluded to is one of the rehab therapists I talked to yesterday said, here's how we do it. If the patient has an SAT and then a coordinated SBT and they don't pass, I have the nurse call me immediately when they fail, because that gives me an opportunity to move in when the patient's awake and actually ambulate or mobilize them while they're still on the ventilator. And what she's seen, again, this is anecdotal, but what she's seen then is that early in the afternoon, the SBT is retried, and the patient actually frequently passes because they've had exercise of their respiratory muscles, mobilization of secretions, and whatnot that we described earlier. So this is another way where the SAT and SBT can actually be coordinated with early mobility, but coordinating, creating a plan, an expectation, a time frame, a meeting around how this can happen does take coordination and cooperation, but that's the way to best collaborate to affect the bundle for every patient every day.
So we spent quite a bit of time going over some strategies, and we want to move this into really understanding, making sure that you know that we know that change takes a while to happen, and that steep curve that you're seeing there, getting to the top of that where it all becomes easy after that, can be a really tough climb. So we want to point out a couple things to you that we think are critical about change. And one is that most of you are early adopters of this. You may have bits and pieces happening, you may be over 70–80%, but you probably started this work or have been involved in this work from an early stage. And we want to encourage you to move in now to getting more of your early majority on board, not focusing on the late majority or the laggards. So as you look at this change curve, really understand that you're trying to pull not people who are the most resistant, not people who will only come in at the tail end, but you're trying to pull in your early majority, your next phase. So you as an early adopter pulling in your early majority. And the piece on that that is important is that you take on a test of change that is doable, that is small. So you can use any process improvement model you would like as you do this experiment. You'll notice, as Diane said there on the left, there's a test of change document that we'd like you to submit. This is what that document looks like in summary. It looks like setting a goal. I would like everyone to have a recommendation in rounds, for example. Or I'd like to try out having a time in which we coordinate. And then moving into what do you think will happen and making a plan. So you know how to make a plan. You do this quite often. Our test of change experiments are based on our process improvement model of Plan, Do, Study, Act, or PDSA. But again, any of your models will work. You list the tasks needed to set up and conduct this experiment, and then make sure you're clear on who's responsible, who will be involved, when and where each task will be done, how you're going to measure results, and then go out and do it. The key piece here is really the doing, getting out as quick as possible. With a small test of change, we often say within the next week or tomorrow even, what am I going to do to try something? For many of our physicians, this looks like I'm going to ask for recommendations in rounds and see how that goes. For many of our physical therapists, it's I'm going to ask when I can mobilize, and can we coordinate that for every patient. So it really can be a very small test of change. Also realize that this experiment and this plan that is there in the document, you can do it as a team or you can do it individually. I know many of you on the collaborative, we have the expectation that you do this as a team, so feel free to do that. We just need one document per team or per individual who's ever on this call and wants to work through their first test of change. So describe what happened, the results that you got, and then send that back in. In session 2, we're going to talk about how your test went, talk to you about what might look like a good next step, and then also talk about how do you deal with some resistance that we know that you will come across because we see it pretty much day in and day out. So we're going to talk about how to deal with some of that conflict or resistance or pushback that you might be getting. So again, your assignment is to conduct an interprofessional team test of change experiment. Email this worksheet back by Wednesday, September 14th. All of this is on the document itself that you can find over under your handouts. The handout or the worksheet is available for downloading. And then you email it in to Diane or Vishaka, and their emails are there and on the form itself. And then we'll look those over, address what work that you did, and we look forward to speaking with you again at the next session on the 21st. We don't want you to take off quite yet. I believe that Sam's going to take back control here, and we're going to move into some questions.
Thank you, Marianne and Dorothy and teams for attending today's session. If you have any questions about the assignment or the requested assignment from today's call, please email Vishaka or myself. And we're going to open up the question box for discussion. If you have a comment or a question, please type it into the question box now. And I have a couple of questions that were typed in while we were doing the presentation, so I'll start with that. So our first question is, the nurses are excited and they're really trying to do this. How do we get our physicians on board?
Yeah, so there's a couple answers to that question. One is, of course, to have a physician champion. And I know that that term is thrown around quite a bit. Often it's a physician who's voluntold that they're going to be part of a project. So it's really important to not just have a warm body in a chair, but to identify a physician colleague, and sometimes it's a nurse practitioner or a physician's assistant who works in your unit who actually has the time and interest and passion around the work that may actually be a great leader. At any rate, having an LIP champion to be able to give orders, help lead the group in the right direction, and influence their peers is very important. That's not always possible, and sometimes our physician colleagues are busy and concerned with other things, and they don't devote themselves to the work. That doesn't mean it stops. Ideally, we want our interprofessional team, of course, to include our physician colleagues. They're incredibly important, as we know, for patient care, but not always able to participate in meetings or planning or spend time away from patients to do extracurricular work. If that's the case, I would encourage you to have meetings and move forward with the work, choosing people that have passion and interest and engagement, knowing that that's the most important piece. The second part is, if physicians are not able or maybe willing to participate in rounds and discuss the ABCDEF bundle, what we've seen work in some cases is that there might be nurse or pharmacy or respiratory care practitioner-led rounds where the bundle is addressed, and any issues that need orders are referred back up to the ordering or attending physician after rounds occur. So again, ideally we want all professions and more that we showed you in that initial pie diagram of the interprofessional team, but please don't be thwarted by the fact that you can't fill all those slots. I would choose people who have energy and passion and move forward. It's a great way to do your PDSA or test of change or experiment in your unit by just maybe starting with 1 or 2 people that have the same interest as you, doing a small test, and then bringing it back and kind of demonstrating how well it worked, and then getting folks to understand that this is important and it's something that can be done and it's something worth doing for our patients.
I would just add one thing on that. Is it's worth the time to wait. Sometimes it's worth the time before you get a whole team together and say, okay, we're moving forward, rather than just sticking anyone in that slot, including physicians. You know, this is a lot of the work that Marianne and I do, is really coaching and consulting around how to pull together a team that really is passionate. So how do you talk to the physician ahead of time? How do you find the right one? And I can tell you, we have some physician leads that have just been waiting to show their leadership skills and to really start to dive into the evidence that they know really can make a difference. And so spending time there. Other questions?
Thank you both. Next, we have another question. It says, in our hospital during rounds, we also include OT and social work in this forum. What are your thoughts about other disciplines being included?
Yeah, great point. If you remember, again, the diagram that we showed, we think that there are 6 essential members of minimum amount of members to discuss and collaborate around the bundle. But we encourage teams to include all disciplines who want to contribute in rounds. Those that were just mentioned are extremely important. So for instance, when we create our interprofessional teams at our hospital affiliates, often we have a speech therapist in the rehab position or perhaps an OT. And it is worthwhile, if those folks are available, to have all of them attend, as they have a little bit of a different frame around what the patient needs in terms of mobility. One thing I will say, though, is in general, in our hospitals, our physical therapy or rehab colleagues, whether speech, OT, or physical therapy, have found that it is not particularly a good use of their time to spend an hour or 2 in rounds. So what they typically do in the morning is they'll round on the patients, they'll do a brief assessment and try to ascertain which patients are ready for early mobility. They'll have that discussion with the nurse, and then the RN will present the rehab perspective in rounds around what the assessment and plan was. And if there's any questions or concerns, the therapist will often pop into rounds to ask those specific things and discuss those issues with the team. So there's different ways. There's no right way. The most important thing is that there's an assessment and a plan for early mobilization for every patient every day.
And having the folks who attend rounds really think about what their role is, and are they there to make recommendations? And if they're there to make recommendations, they definitely belong there.
One of the things that we have seen is many of our teams have pared down their rounds because, for instance, a lot of them were around quality, and this was around people getting information to input about a patient. That's not really the role of rounds in this case. As Dorothy indicated, this is about providing an assessment, collaborating with the group, creating a recommendation, and a plan around that recommendation. And also, when we have too many people in rounds, it often disallows us from moving closer to the patient's bedside, and it also tends to exclude the family toward the back. So there's always a balancing measure between who attends and to understand what their role is in the context of the bundle and make sure they're contributing, but all in all that the essential members are there, and anyone who's added has role clarity around what their contribution is for the ABCDEF bundle. Other questions, Diane?
We have one other question. What recommendations do you have in the implementation of this process when you have numerous interns, residents, new people joining your unit in rounds who rotate through your unit every couple of weeks?
I'll start that one. Scripts. I've seen where there's a rounding script, and as you build that change and there's enough critical mass using it, as new people come in and out, they will want to know what that script says and want to know where we are and who's recommending and what my role is. So it becomes a process of coordination that people just naturally move into. So that is just one thing I would just add, that you have a way of doing rounds that doesn't change with the person coming in and out.
Another perspective on that is we just actually left one of our hospitals yesterday that has multiple rounding teams, right? They have liver rounds and neuro rounds and med-surg rounds, and and often, or most likely, those teams have different focuses and different priorities. And so one of the things to do is to first learn where the ABCDEF bundle needs to live. So as a whole, where the bundle will live, what team will actually be responsible for discussing the entire bundle. For instance, yesterday our team said, well, you know, the liver service doesn't really want our patients to receive sedatives or opioids. But the med-surg rounding said, well, we want to make sure that we alleviate pain using the CPOT scale. So the nurse is actually the common denominator for the patient. And nurses can't attend every single round, or else they'd never be at the bedside. But it is incumbent upon the RN to share information, either contributed or learned in other rounds, with the rounding team who is discussing specifically the ABCDEF bundle. Very, very important. The only other thing I'll say that I've learned is when we have interns and residents, they want to present the whole patient, right? They stay up all night prepping their patients. They have to present the whole thing. The use of the script and creating a culture or behavior around the fact that, okay, intern, we understand that you're on. What some teaching hospitals have done is given the intern a script that says, you give a brief background reason for admission for the patient, and then each discipline reads through the script around the bundle in the way that they're supposed to. And not just for the bundle, this is for all patient care. So the idea is to be willing to experiment with doing things differently, maybe rocking the boat a little bit around how teaching rounds are held, or maybe the ABCDEF bundle doesn't live in teaching rounds. Maybe it lives somewhere else where it can be more effectively addressed in an interprofessional collaborative way.
Thank you, Marianne, and thank you, Dorothy. We are going to wrap it up for today. Just have a couple of things left. Make sure that if you have questions about the test of change that you email myself or Vishaka. You can find that handout under the handout tab print it off and then send it to us. Our second interprofessional team coaching call will be September 21st, 2016 at 1 p.m. Central Time. To claim credit for today's session, please log on to My SECM with your customer ID and password, choose My Learning tab, and scroll down and click the link to assess a post-evaluation and to claim credit. So this concludes our webinar. We thank Mary Ann and Dorothy for contributing today and for the team's questions, and we will conclude the webinar now. Thank you.
Thanks, Diane.
Thank you.